psychosocial treatment in YABA and stimulant youth in Asia. And we have three speakers from Vietnam, Malaysia, and Thailand. So I will introduce each speaker on each session, and then we continue lecture until finished, and then we have a question later on. Okay, so the first speaker will be Trang Nguyen Thu, right? She is a psychologist, PhD, clinical psychologist, and she finished on political science too. She expertise in qualitative research and behavior intervention, and she worked at Hanoi Medical University at Vietnam. Please, Trang Nguyen Thu, right? Yeah. Okay. Please slide.
Good afternoon. Today I will be sharing Vietnam experience with evidence-based intervention to reduce med use based on our research and implementation effort. Here is the overview.
Sorry, what happened?
So over the past 10 years, Vietnam.
So first of all, thank you, the chair, Madam Chair, for the introduction, and thank you for your interest in this session. So I'm very happy to start the session with the lesson from Vietnam. So my presentation is on the evidence-based intervention to reduce methamphetamine use. So this is an overview of what I'm going to cover. So I will first describing the Vietnam shifting drug landscape, then our policy response, and also service gap. I will focus on, oops. Oh, is this? Okay, I will focus on our two studies on the evidence-based intervention to reduce med use, and then lastly, I will cover the civil society and community-based effort to support people who use stimulant. Can you go next slide? I cannot move. Okay, thank you. So. Over the past 10 years, the substance use in Vietnam has shifted from opioids to methamphetamine. I think this trend is really like aligning with what is happening now in the region. So as you can see here, methamphetamine use is really popular. This is the data from our compulsory rehabilitation center, and then almost half of people who entering the compulsory rehab centers are there for methamphetamine use. And med use is also very popular among people with primary opioid use disorder. So that like methadone patients, so this is our survey among nearly 7,000 methadone patients, and we see that more than a quarter of them also use methamphetamine and also use that at a moderate or high risk. Among the people who inject drugs, and you know that injectable drugs are heroin in Vietnam, and we see that the the number of people who inject drugs but who also use methamphetamine is increasing quickly over the past several years. Med use, the increasing med use is really a public health concern in Vietnam, as it now is threatening the achievement of the HIV, the HIV program, as it is associated with the increased risk of unsuppressed viral suppression, and also, what is more important at the societal level is that it fuels the societal anxiety, and that backs law enforcement and more punitive strategy. So the government of Vietnam has been aware of the rising methamphetamine use since the early 2010s. However, the effort mainly focused on developing technical guidelines for medical staff. As you can see here, a lot of workshop and then guidelines for diagnosis and treatment. But then what is like is there is no intervention, implementation guidelines, so that we do not have any services implemented to really serve the people in need. So this leads to our service gap. Currently, we only have methadone treatment as the only evidence-based intervention. And methadone, you know, as you all know, that is only for opioid disorders. Here, these are the current service, the available service in Vietnam. So more than half of people are under methadone treatment. Nearly 40% are in compulsory drug rehabilitation center, which is not effective, and very few percent of people are in voluntary rehabilitation center or in community-based rehabilitation. And we are not sure about the quality of this service because there's no guidelines for the intervention there. Oops. So this leads to a serious need of med use treatment. So to fill in the gap, so in 2020 we have started the first RCT, the first randomized control trial funded by the National Institute of Health in the US to identify the optimal combination of evidence-based intervention to reduce methamphetamine use and to improve the HIV treatment outcomes. The evidence-based intervention that we test include the motivational interviewing, contingency management, the SMS text message, and the matrix counseling models. I will explain our model here. So we recruit. We screen about 7,000 methadone patients and recruit 667 participants. So all of these participants, either they test positive for methamphetamine or either they score at the moderate and high risk on the ACIS scale. So when participants first are enrolled in the study, they will receive one session of motivational interviewing. Then they are randomized into two arms. The frontline, this is called the frontline intervention. The frontline intervention is for the first 12 weeks. For the frontline intervention, people either receive the high intensity, that means they receive contingency management for 12 weeks, or either they receive the low intensity intervention. It means contingency management for 6 weeks, then 6 weeks of group education. So after the first 12 weeks, we test the participant again to see whether they respond to the frontline intervention or they are not. For those who test negative on all the 4 consecutive urine drug tests, they are considered responsive to the frontline intervention, and then they are assigned to the maintenance phase. That means the SMS text reminder. And for those who are not responsive, that means one positive urine drug test in the last 2 weeks, in the weeks 11 and 12, and they are randomized again in the matrix counseling only, matrix plus contingency management. And these are the, we call this phase the adaptive phase, and this also lasts for 12 weeks. So there are 24 weeks of intervention, and by the end of week 24, we assess the substance use and we assess the HIV outcomes. So before we, at the very beginning of the study, before we formally start the RCT, we conduct this adaptation to better fit the intervention to the Vietnamese context. So we use the adapted method to adapt these four intervention. So these are some of the findings from the pilot test, and we see that actually so we conduct the study in the two main cities in Vietnam, one in the north and one in the south, and we see that actually the drug patterns in the two cities are different. For example, in Hanoi, in the north, most people use methamphetamine with friends. However, in the south, in Ho Chi Minh City, most people use methamphetamine by themselves. So this means there are different risk factors for people in the north and in the south. As a result of this finding, we decide to tailor the training material on motivational interviewing and also on matrix and the matrix model to better fit the risk factor of the participant. We also see that actually the motivation to seek treatment of our participant is to protect their family from the lack of self-control under the methamphetamine effect. So as a result of this information, we enhance more, we try to include more information on the impact of methamphetamine on family in own intervention. So that's step one. And then we conduct a focus group discussion and with all of our, so with methadone patients to get their input on what reward are the most would be most motivating to them. And they say that actually methamphetamine treatment fee or phone recharge won't be most needed. So we use this reward for contingency management. We also ask them about different logistic factors, like when we should organize the meeting and when we should, and what topics they are most interested in. Then we have and we have all the intervention material revised and reviewed by the addiction therapist, and to get the final version after 6 months. And then we train the methadone clinic staff, and we pilot test the intervention. So here are some of the pictures on motivational interviewing in matrix group counseling session, and you see that actually this was just after the COVID pandemic, so everyone wore a mask. And these are our reward repository. There are some of the small gifts that the patient can select from when they score, and they can exchange their point they can exchange their point for this gift. And here the patient and the lab technician are recording their result on the sheet, so that they, toward the end of the intervention, they can exchange their point for methadone treatment fee, for example. And for those who are in the maintenance arm, they receive daily text message that cover from ARV adherence or harm reduction on med use or social support. So these are some of the, so these are our findings on the effectiveness of the intervention on med use. And we find that actually intervention works, intervention are effective. As you can see here at the baseline, and at week 24. And what is confirming but not so surprising is that contingency management is the most impactful intervention. So here are the graph comparing the two frontline interventions, the high intensity and the low intensity. The high intensity of contingency management for 12 weeks, and the low intensity is contingency management for 6 weeks. And you can see that actually for those who are in the longer contingency management, they are doing better. They have more negative urine than the one in the low intensity. And here we compare the 4 adaptive strategy. And on the graph, the first 2 lines are the first strategy with contingency management. So consistently, on the intervention that have contingency management are way more effective than the arm that have no contingency management. So to follow up on this finding, to follow up on the success of the last study, we designed another feasibility and acceptability of med use treatment for people with primary med use disorder, but in methadone clinic. So this is just to clarify. So the first study is for methadone patients who also use methamphetamine, and we provide intervention in the methadone clinic. But then in the next study, we target the one who are not methadone patients, who do not have like an opioid use issue. But then because we want to make the most use of the methadone system, so we want to deliver the intervention in the methadone clinic using the same staff. So these are the eligibility criteria for the participant, as I just described. The 2 objectives of this study is that, first of all, we want to know that whether we can recruit participants who are not methadone patients to methadone clinic for treatment of methamphetamine, and also what recruitment strategy would work. And secondly, we want to know whether providing intervention in methadone clinic for those who are not methadone patients is feasible. The design is that at first we will screen, we expect to screen like 600 people at risk to recruit actually 60 participants and then randomize them into 3 groups. The contingency management, then matrix plus group matrix plus contingency management, and individual matrix plus contingency management. And the whole intervention period lasts 12 weeks. I won't explain more on the contingency management used in this study. So from the start and from the last study, we know that actually contingency management is the most effective intervention. So in this study, we use that to target different behavior. So for the first arm, we use contingency management to promote abstinence. So participants receive incentive for each negative urine drug screen they have. And for the second arm and for the third arm, participants continue to be tested every week, but they do not receive any incentive for their urine drug screen result. However, they receive incentive if they attend the groups, the counseling session, either in group format or in individual format. So these are we use like escalating reward for contingency management. As you can see here, the values of each time the person achieve the target behavior, and if they can if they get the target behavior consecutively, the maximum amount of reward they can receive is $134 US. So this is quite significant for an average participant. We haven't yet completed the data collection for this study. However, some preliminary observation, we see that actually the need is there and the need is great. We reached our enrollment target pretty quickly, and much quicker than expected. We only have to screen 246 instead of 600 as intended to recruit our sample size. And then comparing the different recruitment strategy, we see that actually the referral by outreach worker is more effective than respondent-driven sampling. As you can see here, like 32% of people who receive a coupon show at the clinic, while 80% of those who approached by an outreach worker agree to present to at the clinics. The reason for that, when we interview our participants, is fear of the police, fear of stigma, so that when they are referred by someone they trust, like an outreach worker, it makes them more confident in the study. And the intervention were considered feasible and acceptable by both for provider and participant. Of course, the provider emphasized that in order to expand, to scale up the study, it is necessary that more human resources are provided to the methadone clinics. Otherwise, they will not be able to assume to treat both the methadone clinic and people who are not methadone patients. So now I will move to the last part to describe the civil society and also the community-based effort. So these are what are happening now in some of the PrEP clinics operated by social enterprise in Vietnam. So you can see that we are trying to advocate for screening and early intervention for substance use in these PrEP clinics. So every time the patient come for pick up their medication, they are screened not only for stimulant use, but also for other substance. And we focus significantly on Chemsex. And for Chemsex in Vietnam, it's not just, so Chemsex in Vietnam, people use methamphetamine, but also for a very big part, they also use alcohol. And for those who score at moderate or high risk, our counselor provide brief intervention. But then what lacks here is the referral to services, because we have no services available to receive the participant. Our clinics also provide quite a lot of awareness raising campaign. We organize talk show and we organize events to provide consultation on Chemsex, on the use of substance. And we also provide people with harm reduction materials. To conclude, methamphetamine use is increasing in Vietnam, but however, and very unfortunately, that our treatment system is not ready to address that. Our study with people with both opioid and meth use disorder and people with primary meth use disorder show that actually treatment works, but and it is feasible to integrate meth use intervention in the existing methadone treatment system, which is the only the only evidence-based addiction treatment system in Vietnam. And we highly encourage and really we are very willing to join any regional research collaboration to enhance the evidence and to inform drug health and policy strategy in the region. Because one concerning fact that we in Vietnam, we are in the addiction treatment field have now is that the government, our government is tending to move toward criminalize drug use. So this is something we want to make our voice stronger and to have stronger evidence to advocate for a medical approach of the substance use. So thank you.
Thank you. Trang Nguyen Thu. The next speaker, because the time is run out. The next speaker from Malaysia, Professor Vicknasingam Kasinather, right? He is the professor at Addiction at Center for Drug Research, Universiti Sains Malaysia, and he will give the lecture about barrier and challenge for providing treatment for people who use methamphetamine type stimulant, but mainly in psychosocial treatment, right? I think that we have time limit. Can you speak about 25 minutes, can we?
Can.
Thank you very much.
Thank you, Madam Chair. Thank you to the organizers of the conference for this kind invitation. And I was glad to see the remarks at in the morning session during the opening ceremony and the importance of having this conference. When I was given this title to talk on psychosocial aspects for amphetamine treatment, and listening to my colleague who just presented from Hanoi, I think the situation is very similar even in Malaysia. So hence why you see my title is a bit different, because I think even before we reach psychosocial treatment, there are issues that we need to address first, the barriers and challenges, because the treatment for amphetamine use is still very much at an infant stage, very much lacking, and the fear that we have, like my colleague from Hanoi who just said, is the increase in criminalization by enforcement agencies. So again, what I heard this morning during the opening ceremony of how we should start looking at it from a health angle is very important. And to understand why criminalization is taking a more prominent role in the region is, I'll show you some slides about Malaysia to try to understand why this is taking place. So I'll run a bit faster. I think it is obvious for this conference in this slide that we have a big problem in the region, a very large problem. And while in about 20-25 years ago, the HIV epidemic hit the region very badly. And at that time, we had a problem with opioids. Heroin was the main drug being used. Therefore, we had an opioid epidemic, and the HIV infection was driven by the opioid epidemic. So we came up with harm reduction very quickly. Within 10 years or so, we brought down the HIV infection rates. I'll show you in subsequent slides. But we continue to, when we moved towards or adopted harm reduction, we didn't really change the drug laws in Malaysia, and I think also in many other parts of the region. So we adopted harm reduction without changing the laws. And this has come back to be a bit of a problem now when we don't have a heroin epidemic, we have amphetamine use, the enforcement agencies go back to enforcing the laws. So this is some of the issues. And the region continues to have a prohibitionist approach. I highlighted Singapore here because while being a very small country in the region, they are they push the prohibitionist approach. With the ASEAN group, they have an ASEAN ministers for drugs meeting, and they continue to push this, drug-free society, drug-free ASEAN, which sometimes I think when you push this kind of slogans, it is counterproductive to the health interventions, because people, society out there expect that one fine day we're going to solve the drug problem. So in Malaysia, again, the main problem, like many other parts of the region, it is amphetamine type stimulants are the main drugs being used. You can see opioids, heroin has reduced tremendously, and this is the same in the whole region. So when did ATS start becoming prevalent in the region? This is something that we did from surveys in Malaysia. You can see at the beginning of the century, about 25 years ago, and I think very similar to many other parts of the whole region, I think, was flooded with amphetamines from year 2000 onwards. So like I said earlier, the HIV epidemic was driven in the region, I think, mostly by heroin use, heroin injection. And with harm reduction, we managed to reduce within about 10 years the infection from sharing injection equipment to MSM infection. So now you see in Malaysia, the epidemic is driven largely by MSM, MSM infection. But what we do not understand in this MSM infection, the infection is recorded as an MSM infection, but we do not understand to what extent this behavior is caused by drug use, which is amphetamines. We look at Chemsex. There's not much done. This a colleague of ours in Malaysia has done a study, but we still do not understand the nexus or the relationship between Chemsex, ATS use, and HIV infection. So is this driving the HIV epidemic among the MSM population? Untreated ATS users is something that more research needs to be conducted, I guess not only in Malaysia, but in many other parts of the region, to get a better sense of what is driving the HIV epidemic among the MSM population. There are treatment protocols or guidelines, how treatment can be provided for people who use stimulants. This is an UNODC, UNAIDS, WHO document developed. Then there is the UNODC document, Treatment of Stimulant Use Disorder, developed also. But what I notice is we are not adopting or using them as widely as we should. I'm not sure how many of you know that these two documents exist, technical guide and a discussion paper. So there are very important points here that are made based on consultation with many stakeholders. But I don't see us in Malaysia using this, or the Malaysian government using this kind of documents to guide policy, to guide programs in the country. So as far as research that has been conducted, we conducted a similar study like what Hanoi did as well, with co-use of opioids and opioid users undergoing treatment with buprenorphine and who also had ATS use disorder. So we used atomoxetine in this RCT. It showed some promising results, but it was a very small study. We could not get funding to carry out a larger study. So there needs to be research, more research on ATS use combining possibly medications and also psychosocial interventions. But as of now, we do not have any medications, but the only mainstay that we have is psychosocial interventions. And this is another publication of ours when we talk about legal challenges in providing treatment for people who use drugs in Malaysia. Malaysia has a very unique situation or a very unique way of how they manage the drug problem. Is we have two major acts. One is the Dangerous Drug Act 1952 and the Drug Dependence Treatment and Rehabilitation Act 1983. So the Dangerous Drug Act 1952, the owner of the act is actually the Ministry of Health. These are all the scheduled drugs that are banned and so on. But the main agency that uses these drugs, uses this act or implements this act, enforces this act, is the Malaysian police. The police uses this act mostly, whereas the Drug Treatment and Rehabilitation Act is by the National Anti-Drug Agency, which comes under the Ministry of Home Affairs. Even the police comes under the Ministry of Home Affairs. So they largely control even the treatment aspect as well as the enforcement. And then this act was amended in 2024. I'll tell you later what were the slight amendments. So under the Dangerous Drug Act 1952, if you look at this DDA, there is a section called Section 15.1. It can be used for people who consume drugs. That means they do not have to show determined dependency. The enforcement agency just has to test your urine. A mere urine positive is enough to either send someone to prison or to be fined under the criminal justice system. And subsequently, under Section 39C, if you have been convicted twice under Section 15.1, they can use Section 39C to enhance the sentence, prison sentence between 5 to 7 years, including with whipping. So this is where enforcement agencies use this law, where when they detain someone, they do not have to produce the drug user to a treatment provider, but a mere urine positive is sufficient to send someone to prison or to get someone fined, and with harsher penalties if you have been convicted twice. And when did the government start using this act? If you look at it, the government started using this act as the types of drugs changed in the country from heroin to amphetamine type stimulants. Why do they do that? Because the next act, if you look at, is the Treatment and Rehabilitation Act, which is used by the National Anti-Drug Agency. Under this act, if someone is detained suspected to be a drug user, and if the urine is positive, they have to bring that person to a medical officer to be certified as a drug user, okay, or as a drug dependent. So the medical officer has to certify drug dependence before someone can be sent for treatment in the institutional rehabilitation center or in community-based treatment. But if you look at the number of people that have been, which the police uses under Section 15.1, which is for use of drugs, that means no rehabilitation, no treatment, straight to prison or straight you are fined, the numbers are very high, say like 85,000 people. And then you look for Section 39C for increased penalties if you've been convicted twice, which I said earlier, the numbers are also increasing. But if you look at the numbers that are treated for under the Drug Treatment and Rehabilitation Act, the numbers are very low. They are only about 10% of what the number of people that are being sent to prison. And why is this so? This happened, these numbers changed drastically when the types of drugs in the country changed. Because when enforcement agencies used to bring heroin users to the medical practitioner could certify dependence even if he was not a trained addiction medicine specialist, because opioids or heroin use, there was visible withdrawal symptoms. There was physical withdrawal symptoms which medical officers could observe and therefore certify dependence to opioids or heroin. What happened was, when amphetamines became prevalent in the country, when enforcement agency officers take a detained or suspected drug user to a medical officer, the medical officer was not willing to certify dependence, because with amphetamines, methamphetamines, you do not see physical withdrawal symptoms immediately, because the withdrawal symptoms are more psychological. Therefore, physicians were not willing to certify dependence, and the person could be released. So therefore, enforcement agencies started using the Section 15(1) under the Dangerous Drug Act, which then limits or does not allow for any treatment to be provided for ATS users. So this is a major challenge for us in trying to get more people to provide treatment, but at the same time, enforcement agencies continue to arrest, detain, and also imprison large number of drug users. I showed you the number was about 85,000 people in 2023. So these 85,000 people, their opportunity for treatment is just not there, compared to only about 7,000 or 8,000 people under the Drug Treatment and Rehabilitation Act. So for us to provide any form of treatment, I think the legal provisions in the law has to be looked at very seriously before we talk about even providing treatment for ATS users. And I think this is one of the reasons why many enforcement agencies want to go back to criminalizing drug use, because they say that they don't understand psychosocial interventions. When you talk about treatment, enforcement agencies always expect some medicine to be put into your mouth. So with methadone, there was something that they were consuming. It looked like medicine, therefore it was considered treatment. Psychosocial interventions, how do we now package psychosocial intervention as treatment to people who do not understand this? Yeah, so this is one of the challenges that I see, not only in Malaysia, but I think also in many parts of the region, that enforcement people do not understand. And this is also one of the challenges, because we don't have a medicine right now for ATS users. Is psychosocial interventions, they're going to take a longer time to show results. So, like I said, last year, the Malaysian government amended the law. But we as researchers, we were unhappy, because the law that should have been amended was the Dangerous Drug Act, where the 85,000 people that are being sent to prison by police, that act should have been amended. Instead, they amended the treatment and rehabilitation, where only about 8,000 people are sent for treatment. So they didn't amend the law comprehensively. They amended the law that was where the minimum or the smaller number of people that are being treated, to include some of the things that they did was to increase the or expand the powers of the National Anti-Drug Agency, and they also with voluntary treatment and so on. But we were still unhappy because the medical practitioners were still not brought in actively to be engaged under this new law. The National Anti-Drug Agency still comes under the Ministry of Home Affairs. they have still wide enforcement powers, and our efforts to bring in the health fraternity into this, to provide more health-based interventions were not very successful. The government pushed ahead. We don't understand why, but I think they listen more often to enforcement agencies rather than the health or the research fraternity. So the challenges and the conclusion is, if we talk about psychosocial treatment, the main problem here is the drug policy itself, the challenges in the drug policy, not only in Malaysia, but also if you look at the regional perspective in Southeast Asia, ASEAN meetings, they always still talk about in a prohibitionist approach. We need to understand the relationship between ATS use and Chemsex and what is driving the HIV infection, for example. We need to develop capacity in effective treatments for ATS users. Like I said, psychosocial interventions are almost non-existent, if I can use that word. When we started methadone program, and this was also one of the weakness of the methadone program. Because the region, if you look at it, 25 years ago, the medical fraternity getting involved with the drug problem was very minimum, or if not even existent. A lot of the treatment were institutional-based programs where they keep them in a center for 1 or 2 years before they release, and it's all handled by enforcement. So what happened during harm reduction? We had methadone, we had needle syringe exchange. We gave methadone to people who use drugs, but we never provided the psychosocial interventions. The psychosocial interventions were there as part of the manual for treating in the harm reduction manual, but it was not provided at all because the capacity was there. But it still worked because we had something like methadone. It was very effective. Someone experiencing withdrawal symptoms come into the clinic, they take their methadone, they feel very good, they're able to function, and therefore we had very successful rates, successful programs to demonstrate to the government that people were doing well. But what happened with these people were, after they were doing well, they stopped heroin use, amphetamines came into the country, and because there was no psychosocial support, psychosocial interventions, they stopped using heroin, but they needed something to have a good time. Most of them started using ATS, amphetamines, methamphetamines, because they needed that stimulant effect. They all were doing well in methadone program, they started using methamphetamine. And this was partly because we did not have psychosocial interventions for them. And that's a group of people that we have, a group of drug users. Then now we have methamphetamine users who only use these two drugs, the younger ones, and we do not have anything for them. There's only psychosocial interventions, and we have not developed. Psychosocial interventions are still very weak in the country, and hence probably why enforcement agencies are getting stricter and they want to enforce the laws, because on the treatment side, we are also not ready to provide interventions. The psychosocial interventions part is still very weak on our side of the treatment side. So the enforcement say, the numbers keep going up, you can't do much, you don't have, to them, the understanding of treatment is a medicine that you needs to be taken orally, probably. So you don't have anything like this. And then what do we do now? So to them is we come up with laws and stricter enforcement policies. So this is causing a problem for us. So I think there is a need to integrate harm reduction as part of the national drug policy. Like I said earlier when I first started the talk, was we implemented harm reduction without changing the laws. And this has come back now to become a problem for us because the enforcement agency says, in many of my meetings in Malaysia with enforcement agencies, your HIV problem is over, drug users are not the problem for HIV anymore. So you have done it, so now, but they continue to use drugs, now they're using YABA, so let's start enforcing the law and to arrest them. And we don't have an answer on our part as treatment providers because our psychosocial component is still very weak in the treatment part of it. Thank you very much. With that, I'll end my talk.
Thank you.
Thank you, Professor Vicknasingam. Okay, the last speaker will be Ajahn Daruni Phuklao. Are you professor already?
No, not yet.
Not
just
yet.
assistant.
Assistant
professor.
Assistant Professor Daruni Phuklao, she's a nursing, but she went to Australia to study PhD program in addiction study at Queensland, and now she works in Mahidol University, and she expert in motivational interviewing technique. So she will present about the motivational interviewing in Thailand.
Yep. Okay. Thank you very much ค่ะ
Thank you.
Thank Professor สุวรรณานะคะอาจารย์หมอสุวรรณาค่ะแล้วก็ I also got my advisor นะคะ PhD advisor here นะคะ Thank you very much. It's not my slide ค่ะ Another one ค่ะ Okay ค่ะ I think it's really honor to be here as a lecturer, like you said, from Faculty of Social Science and Humanity. Right now, I work in Faculty of Social Science and Humanity, Mahidol University. We really gratitude to have a chance to be a representative of Thailand and share about how psychosocial treatment and focus on MI is look like in our country right now. Okay. I think I got the invitation to give this talk last 2 weeks. It's quite overwhelming for me, and I try to work out what I can share. Okay, in these 2 weeks, the first thing that I did is I just share with you. I tag my friend to Facebook. Okay, I just share story a little bit during waiting for the slide. I tag I think around 10 friends. Okay, through my Facebook, and all of them work in addiction service in my country. In my country, that working in psychosocial treatment, okay, area. I talked to one work in the biggest addiction hospital is called PM NIDAT. Okay, or SBYOSH in Thailand. I don't know that some of you here, and also tag all. My colleague in every addiction hospital, Khon Kaen, Songkhla, Pattani, okay, and ask their idea that, okay, if I have to be representative of my country, talking about psychosocial treatment, what you would like me to share, okay? And for 10%, let you guess how many person that I got. When we do research, we send 100 questionnaire. Normally, how many we got? Yes, exactly. I got 3% back. Okay, 3% back. But they give me very nice reflection. They gave me 1 or 2 or 3 pages. Okay, and then they reflect about their journey as a health practitioner. Okay, working with stimulant user in Thailand. I think it's very good. And from that, I come up with the structure of my presentation. From their 3% idea. So I put my structure into 4, okay, 4 agenda. The first one, I will share about the national structure, our national structure about psychosocial treatment. So I got this information from my network in PM NIDAT, Big Addiction Hospital Institute. Okay, they show me what kind of psychosocial treatment that they have. okay, because like normally PM9 affiliate with like Ministry of Public Health Thailand, and they got like big responsibility to train psychosocial treatment to the health personnel that work in Ministry of Public Health. That's really big organization. I think more than like 10,000 nurse, psychiatrists, psychologists all over, okay, that have like capacity or have responsibility to like talk and provide psychosocial treatment in our country. Okay, that's for the first part. I will share that. And for the ค่ะได้เลยค่ะโอเคค่ะได้เลยค่ะโอเคค่ะ for the second one you still with me, okay, waiting for them. Right now I still talk that the full structure of my talk conclude the component of my talk, okay. And for the second one I will share about listening from the ground, okay, that I got information from my three colleagues. And so from that I will go to my contribution, okay, about MI that you mentioned, both my personal contribution toward this psychosocial treatment approach and also the system level contribution. Okay, I think I contribute two level about MI. And then from that I try to synthesize, okay, the third data, both like from national data from PM9 and the second one listening from the ground, okay, and from my personal and system contribution about MI. I synthesize that and propose to the future direction of MI work in my country, okay. So that's my structure of my presentation. Okay, still waiting. I can go. Okay, for the first one, okay. First one, I will talk about the national structure about psychosocial treatment. When talking about psychosocial treatment, which the name come up to you, cognitive behavioral therapy. Anyone heard about that? CBT, matrix model, motivational interviewing, ACT, ACT, okay, EMDR, what else? Schema therapy, SATIA, what else? What else? Dialectical behavioral therapy, contingency management, okay? So we have like plenty kind of psychosocial treatment that I heard all over for 20 years, okay? For me, I finished PhD in addiction study, Department of Psychiatry, University of Queensland, and my advisor here, she guided me to address two intervention, two psychosocial treatment. The first one is MI, and the second one is CBT. So when I study PhD, like my advisor said, no, you are Thai. You cannot like copy Western intervention. You can interest, okay? You can interest MI or CBT, but you have to make one yourself. Okay, that's my my question that my advisor asked me, okay? But anyway, I got a chance to learn a lot about MI and CBT when I did my PhD. And so how it relates to like a national structure in PM9. Because right now, you know, in PM9, they got three kinds of psychosocial treatment right now, three kinds of intervention that they got training, okay? They got training program. I told you maybe more than 10, okay, in advance that we got like in Thailand, we got so many psychosocial intervention, but beyond three, okay, beyond three intervention in PM9, okay, is in the university, okay, lecturer go to abroad and learn about a lot of like psychosocial treatment, and then they build empire themselves, okay, like they do a lot of research and they do a lot of training themselves, okay, they pursue their like interest. But for like PM9, they got, okay, this is the structure of my talk that I mentioned about, and right now I already mentioned about this, okay, psychosocial treatment that we heard a lot, okay, and I'm talking about this, okay, this is PM9, okay, PM9 right now they got like matrix model, okay, they got like CBT, interesting, they got like CBT 2 level 1 and level 2. Level 2 like they cover co-occurring disorder. I think it's really advanced. in our country, that like addiction hospital, that they interest in like psychological as well, and they like train CBT for co-occurring disorder, like both people who cause like addiction and plus psychological disorder. And the last one is MI, okay, MI 2011. Okay, they invite me, look at me, young Daruni at that time, look at me, like they invite me to like develop the MI training. Right now is 25, last 14 years ago that I worked with them, I brought my like colleague, lecturer, and also my PhD student. Suthida also still here, sit here, social worker, like, and this is like she really experienced in matrix program, but they help me, and this is my PhD student, okay, and we all together set up 3-day training MI, okay, and we like do some training. Right now they need me only 3 hours, but around 3 years, 2011 to 2015, they need me 3 days for helping them to train. But right now, just 3 hours. That's really good for them, okay? They're doing really good. Okay, so this is like 3 things that our big addiction hospital provide to all the health practitioners that work with stimulant user in our country, okay? So what I see, I think that for 20 years that I work with them, not 20 years, yeah, around 15 years, I see that like for people that I talk about and I train them and work with them, I see some shift from fixing people to working with people through MI. Okay, from doing to client to working with the client. Over 20 years of like system like MI implementation, we now see important opportunity to strengthen the foundation of our psychosocial care system. I see opportunity to deepen MI integration, not just as a technique, but as a stand for human-centered care. And one thing, I think we need for fidelity support system. Okay, because right now when we talk about MI, we don't know that whether we do MI right. We just do it by heart. Okay, just train with like PM like that trainer. Okay, and really enjoy. But we don't know that how much they do right in terms of MI fidelity. Okay. And so that's for the part 1 I finished, okay? For the second part of my talk, I will share with you, that what I got from listening to the crowd, okay? That from the crowd, what we heard. This is a couple of sentences that I got from my colleague that they wrote to me. Actually, they wrote to me very long, but I choose the thing that both of 3 of them wrote, okay? Something that they agree, okay? But 3 of them, they don't know each other before. But the content, we try to support those stimulant users who have experienced violence. Okay? But no one help us understand how to hold that feeling. The second one, we are holding our own trauma. This is health practitioner. While witnessing others. The third one, we infuse the spirit of MI into the training process. That make the process very fun, Ajahn. Okay, this is thing that we heard from the crowd. So I like try to like analyze, what behind the voice? What behind the voice? Is that burnout? Is that compassion fatigue when you work with people? Is that secondary trauma? Okay. Is that lack of systemic support, okay, for this group of people? And for other one, we infuse the spirit of MI into the training process. For me, I think that, it's very good when I heard about this, that MI could not just only technique, but it's energy that can help people to use, and they gain more like energy, and they have fun, work with that. Okay, this is like two things that I learned from like listening from the crowd. Okay, and this is like quite quite the same as my research because like I've been done. I really like for 20 years. I really interested in like health professional quality of life. Okay, and I found that like some of like research that I did also show that right now health personnel like faced with some burnout and also compassion fatigue when work with the client who got like addictive use disorder, including stimulant user. Okay, and so from that, like what this white taught me, okay, I think that what we need is not just new psychosocial treatment right now. For me, we don't need like new manuals, but we need new ways of listening, understanding, of being with each other. That's what I thought. Okay, so from those voice brought me back to MI. Okay, motivational interviewing. Okay, not just as a method, but as a way of being. Right now, if like people interested in MI, MI got 4 versions. From 1991 when I studied PhD, I reading this one, the text of MI. And MI also like grow along the way. Right now, version 4, motivational interviewing, helping people change and grow. Because they said that, hey, for 3rd version, we just only help people to change. But we did not realize that people that sit in front of us, they can grow. Okay, so they add the growth version in this like MI version 4. Okay, so I go to the 3rd part. What my MI contribution journey? Okay, both like personal foundation and system level contribution. Before 2019, okay, I just like training. Okay, people invite me, I think more than 100 times that I went to maybe like 40 provinces all over Thailand and train MI for 3 days. But have to gratitude to my advisor because I still remember last 20 years I cannot teach. I cannot teach, no. I just said that like I still remember you invite me last 20 years ago and you said that it's okay and if you cannot teach, you just do it. You just do it. What did you do with your client? And you like give me 5 clients, I still remember. I do MI and CBT with them here. Like in, what's that called, in the panel and then like you just like, watching me doing MI and CBT at that time, and you ask me question when I like finish running with the client, I still remember. Okay, so like for the period before 2019, I just do some training. For 2019, I start to do scoping review. What MI research look like in my country? How much is that? And then I go to like apply, no, for being like MINT membership. Okay. And then I start to do like system level contribution. I like taken pioneering step by introducing the first structure initiative to assess the fidelity of MI practice. And then I develop MI elective course within the health social science program, offer both master and PhD program. And I got one of my PhD doing MI. So in Thailand, I think we have just only one person doing like MI as a PhD level. Sorry, I don't know that other university got like MI PhD level or not. And then I developed a Thai MI network. Okay, and person who pushed me sit here. I think Trang Nguyen Thu here, he is the first person in Thailand that study MI and contribute MI to our country. Thank you, Ajahn, to push me to set up the MI Thai network. And I organized the first Thai national MI conference last year. So let me tell you a little bit for all of that. This is scoping review. I learned a lot about this. Scoping review of like 20 years of MI research in Thailand. Okay, and I used like 3 data sources. Okay, I got allowed 66 paper, research paper at that time. I finished it allowed like a couple of years ago. Like I found that research about addiction is allowed 50% ค่ะอาจารย์นะคะ 50% that use MI in addiction area นะคะ both like game addiction, alcohol, stimulant user, methamphetamine นะคะ allow like 50%. Apart from that we got like for NCD, MI for NCD ค่ะ but this is the type of research นะคะ that we found นะคะ a lot of them นะคะ 78% นะคะ outcome evaluation research นะคะ we have only implementation research just only one นะคะ just one project นะคะ use implementation research. That's why I really gratitude for professor from Vietnam เนาะ that you like conduct really big like implementation research ค่ะ okay from that นะคะ I found that we need นะคะ we have a gap นะคะ there is still no research in Thailand addiction context that apply implementation research to die the use of MI. More critical research นะคะ should be done to examine the use of MI with Thai population delivered by Thai health professional in Thailand context from several lens of social science theoretical perspective outside psychology to move the MI conversation forward in Thailand academic MI communities ค่ะ and the last one นะคะ there is a lack of systematic effort to evaluate the fidelity still ค่ะ โอเคค่ะ from that นะคะ I apply นะคะ when I finish scoping review I think that we need to learn more even if I'm PhD in MI I think I need to learn more and then I apply to be like MINT network นะคะ MINT network is set up by people who set up MI the founder of MI นะคะ Miller นะคะ Miller is a psychologist Professor Miller he set up MINT okay and right now นะคะ I think in this region นะคะ we got Thailand I put Thailand here one person นะคะ I'm MINT member so what I got for being their member I got like invitation to attend their conference and update my knowledge about MI that is very good I learned a lot because right now MI growth a lot and I learn more about like their strategy their theoretical behind this psychosocial treatment intervention. Okay, and then what's next? After I learned, I know that okay, right now we got a lot of like MI fidelity tool, but never found that in my scoping review. Okay, 66 Thai MI research never use fidelity tool of MI. So I start to like translate and use two fidelity tool. The first one is called MI West. Okay. With like my student and also the pupil that I train. Okay, I think it's really interesting. Okay, because when we got this tool, we learn more. Okay, in Thailand. Okay, we learn that the skill that show the most improvement after I teach them 3 days is empathic skill, empathy. Okay. But for skills that are challenging to develop includes the first one is called discord. I think if you learn about MI, you know about this discord or resistance. Okay, when people say to you that hey, you are like a therapist, you come, you work with me with stimulant, you used to use stimulant yourself. If you never use, how come you can help me? So this is one kind of like discord. Okay, and MI like teach you to like aware of this discord and how to roll with this discord. And I found that this skill is quite like challenging, like to teach and to improve. Another one is illicit chain talk and also developing discrepancy. But the most challenging skill is like discord, especially when related to information about criminal offense. It's very difficult for therapists to work with the client that do something wrong, criminal offense, like they say that it's very difficult to like rolling with discord with them. So I think it's very good because when we know about this, we can like improve our training. Okay, and this is another one. It's called Mighty. Okay, this is like quite complicated, but it's used like when I apply as a member. The first I think first workplace that invite me to teach and train about this is like faculty of nurse in Mahidol University. She would like their nurse lecturer to apply member and know about this like fidelity tool. Okay, I go on to like this is my subject, no MI subject that I teach. I call like MI in health social science. Okay, because I got the some sort of like social science when I work in like social science program, and like the component that I in my MI program is both skill in MI. As you can see, MI deliberate practice, I use like some sort of technique that I learned from Min. Okay, experiential exercise, role play, reflection, and then I also like I think this is quite thing that I like move forward myself as well. Okay, like I try to teach them about structural competency. Okay, what kind of like system that oppress your client. Okay, and how you can like talk with them if they got a lot of like they like oppressed by like their system. All right, okay, and then this is the my Thai MI network. Okay, we set up seminar. อาจารย์คะ maybe like 2 months time, okay, we set up seminar, we just like update MI knowledge that I attained in like Christchurch or Copenhagen, okay, and maybe some like new knowledge evoking in MI, okay, so that that's our like MI network. We got I think around 30 ไหมคะอาจารย์นะ 30 MI person from like several kind of like profession, and one profession is like family medicine. We very honor, and they said that อาจารย์ you know that in family medicine right now MI as one competency of family medicine, they train family medicine to use MI. I think is very good ค่ะ and really like next good move in our country. Okay ค่ะ so I think that's it ค่ะ this is like MI National Conference last year. Okay, we invite Miller to come along with us. We have อาจารย์พิชัย is also another founder นะคะ MI in Thailand นะคะ I learn from him a lot ค่ะ okay ค่ะ and like the more I work with MI, you see like I talk a lot that how I like contribute. The more I see the deeper challenge that still remain from myself. Okay, so this is challenge ค่ะ I found that I got like I can like summarize to 3 challenge, and then I will propose future direction of MI in our Thailand next นะคะ Challenge 1, we still lack of fidelity integrated research, because for me I just do like pilot research, not big research yet. Challenge 2 is MI research is not politically neutral. Challenge 3 is like narrow disciplinary lens. Okay, this is challenging. Okay, that I failed. For this one, I would like to like address this one. No? When talking about MI research, it's not politically neutral. What does this mean when I talking about this? This point invite us to ask critical questions like, who define what MI is, and what counts as success? Although MI research is often framed as scientific, it is in reality embedded within power structure that highlight only certain perspective. For example, it may focus on behavioral outcome while ignoring social and power dynamic. I really gratitude when you mention about this a lot. It often emphasizes client change without questioning the structural force that constrain those clients. This opens up a crucial question: how can MI used not as a tool of control, but as a tool of liberation? Okay, so from that 3 challenge, I propose strategic direction for advancing MI in my country. The first one, we need research knowledge development. We need to design MI research question that emphasize both fidelity and Thai context. We need to develop standardized and localized fidelity assessment tools. We need to promote implementation research to embed MI within real system, not just only one hospital. Encourage, the last one, we should encourage critical MI study through interdisciplinary, social science, and justice-oriented lens. The second one, I propose like curriculum and capacity building. We need to develop MI curricula integrating structural competence and soft power communication. We need to create learning pathway for MI helper, trainer, and MI supervisor. We need to use experiential tools, deliberate practice, role-play, and reflective exercise. We need to train MI informed leader within mental health and addiction health and social service system. Last one, I propose about ecosystem and system implementation. We need to embed MI in national health, addiction service, and university system. Right now, I'm doing university system. And establish emotional and structural support for practitioners. Use MI to bridge gap between client, provider, and policy. We let MI evolve into a shared language of healing, moving from behavioral control to dignity and relational care. And we will cultivate a culture of care in institution and frontline service. This is my last slide, key takeaways. Okay. MI in Thailand is at turning point from what I see. Let MI be the voice that connects, heals, and transforms. And the last one, let MI be a way of doing psychosocial care for stimulant user in Thailand. Thank you very much.
Thank you for Dr. Daruni Phukhao that give our excellent idea about the MI. It changed my idea. Once, I think that MI is very simple technique, but you make it like a certificate, more deeper and deeper. It's not only technique, but it's understand the human life, human dignity, something like that. It's very difficult. Okay, now it's 5:30. It's late for 30 minutes. So have any question for the last session? Please. Have any question for our speaker? No? So I want to thank every speaker in this session, and thank you for participants. Listen until the last minute, late for 30 minutes. Thank you very much. So I close this session. Thank you.